Hey guys, I put together some slides going over EKG findings and the differential diagnosis for each of these findings. I did one of my away rotations up in Cleveland, and during that rotation, one of the attendings there that was actually retired gave up 3 days out of the week for about an hour every day to just go through various EKG findings with the medical students as well as the residents. And during these hours, like he would just go through tons and tons of EKGs, and anytime he found something in a particular spot in the EKG, he would stop and make you give a short little differential for each of those findings. As painful as it was, I thought it was really helpful in terms of just figuring out what's important in an EKG and what you can kind of dismiss without being worried that you've forgotten something or that you've missed something. So being able to put together a short differential for each of these various findings that I'll go through here, I thought was really helpful for me, just in terms of being able to put everything together and being able to throw away the stuff that's kind of there just to kind of distract you. So I'm not going to go through everything. EKGs can be pretty nuanced and complicated. And if you want a short little refresher on the basics, you can click on this link and you'll be able to find what I've created previously. If it's helpful, great. If not, please let me know if there's anything I can improve on. I'd be happy to answer any questions and work on this PowerPoint further. So going on to the more advanced stuff, like I said, this is going to focus more on the differential diagnoses of different findings. Here's a list of everything that we're going to go over, just short differentials for each of these findings. Like if you look further down at items 6 through 9, you can see that lead V1 is particularly helpful, and you can come up with a number of diagnoses just based on that one specific lead, which was something that I learned during my time on my away rotations this past year. So moving into left axis deviation, you all know how to figure out that something is left axis deviation. I'll go over that briefly in a little bit. But moving more into the broad categories of the differential diagnosis, you have four big things: hypertrophy, conduction defects, infarct and scar, as well as just a variant of normal. So with hypertrophy, the main thing is left ventricular hypertrophy. And if you think about it, this makes intuitive sense. With more wall thickness in that left ventricle, there's going to be more area for the electrical signal to pass through the heart muscle, so it's going to push your axis more towards the left. So moving into left ventricular hypertrophy, there's many different criteria, but the one that I tend to use the most is the Sokolov-Lyon criteria. And this basically just has you look at the depth of the S wave in V1 and then take the tallest R wave in either V5 or V6, and then if that total sum is greater than 35 millimeters, then you can say that there's left ventricular hypertrophy. One of the other criteria is that if you look at lead AVL, if there is a tall R wave, I think greater than 11 millimeters, you can then say there's LVH. I've had some attendings say that this is pretty helpful. Some attendings say that it's the most specific, and then others that say that it's not particularly helpful. So I look at usually both of those criteria to determine if there's left ventricular hypertrophy. And the reason that, or looking into the differential diagnosis, the way I understand this is that all of these entities, the hypertension, the stenosis, the regurg, all of those entities are concepts that increase the strain on the left ventricle. So in response to that, the left ventricle will then become hypertrophied because it needs the more musculature and more mass to be able to push blood through, a stenosed aortic valve or aortic coarctation. So looking at this example of left ventricular hypertrophy, you can see a deep S wave in V1 as well as a really tall R wave in V6. And in V1, if you count the depth of that S wave, you can see that it gets pretty close to 15 millimeters. And if you count the how big the R wave is in V6, you can see that it gets pretty close to 25 millimeters. So if you add those up, it's about 35 millimeters, and that meets criteria for LVH. And then on top of that, if you look at AVL, you can see that the R wave there has a height greater than 11 millimeters. All of that's consistent with the LVH. So you wouldn't have any issues diagnosing that in this EKG. So moving on to a left anterior fascicular block, this is a concept whereby one of the fascicles in the left ventricle is blocked, basically. So there's three main fascicles in the heart. Once you get past that bundle of His, you have the one that goes into the right ventricle, and then there's two that goes into your left ventricle. So this is the way I think about it, is that the left anterior fascicular block is a subtype of a left bundle branch block. So looking into how to diagnose it, what you'll end up seeing is a very small Q wave in lead 1 and AVL, and in that same lead you'll see a pretty big R wave. And I don't think there's a height criteria or a millimeter criteria. It's basically just if you see something that kind of fits the pattern, you can say that there's a left anterior fascicular block. And then on top of that, on top of the criteria that is in lead 1 and AVL, you have the inferior leads 2, 3, and AVF, where you see a very small R wave and then a pretty deep S wave. And as long as the QRS duration is somewhere between 80 and 110 milliseconds, you can say that there's a left anterior fascicular block. So looking into a couple examples, the QR complexes look like this in leads 1 as well as AVL. And then in the inferior leads, you see something that looks like this. So you see here that there's a small R wave and then a very deep S wave in the inferior lead. So you'll see a pattern like this. And when you combine the two, you get something that looks like this. So here you can see that in lead 1, we have those small Q waves as well as big R waves. And then in the inferior leads, you've got those small R waves that go into deep S waves. And once you see this kind of pattern with the left axis deviation, you can then say there's a left anterior fascicular block. So just a quick overview. Again, the main things that I worry about when I see a left axis deviation is hypertrophy, specifically of the left ventricle, as well as the left anterior fascicular block, anterior wall infarct or scar, or a variant in normal, but it's obviously going to be a diagnosis of exclusion. So moving on into the right axis deviation, just as a quick reminder, these are typically when the majority of the axis is down in leads 1 and upright in lead 2. The other things that the other leads you can look for is down in lead 1 and upright in AVL. So going with the same kind of scheme that we used with left axis deviation, looking at the differential, I look for things that going into hypertrophy, a conduction defect, or an infarct or scar, or a variant of normal. So kind of like with the left axis deviation, you get right ventricular hypertrophy, which can cause your right axis deviation. You can get a left posterior fascicular block or a lateral wall infarct or scar. So going into right ventricular hypertrophy, this is something that you kind of look for in leads V1, and the things that will kind of trigger you to think that there's a right ventricular hypertrophy is the RS ratio is greater than 1. So basically, anytime the R wave is taller than the S wave is deep. So this can also be classified as a dominant R wave, anything greater than 7 millimeters in lead V1, or a QR pattern with the small Q wave. The other chest lead criteria for right ventricular hypertrophy, I don't know if any of these are particularly helpful in terms of memorizing, but they're there if you want to memorize them. I typically don't even look at them. So moving on into a left posterior fascicular block, this is basically when that other fascicle of or the posterior fascicle gets blocked as opposed to the anterior fascicle. Remember I said there was two fascicles that split and form the fascicles that conduct electricity to the left ventricle. So this is basically the opposite. So if you can remember the left anterior fascicular block, just reverse it, and you can remember the left posterior fascicular block. So in leads 1 and AVL, you get that small R wave and a deep S wave, whereas when we were talking about the anterior fascicular block, that pattern was in the inferior leads. And then in the inferior leads, in the posterior fascicular block, there is a small Q wave and a really tall R wave. So the way I basically just remember the anterior fascicular block and then just remember that the posterior is the opposite of that. So I'm pointing out the specific complexes in 1 and AVL, that small R wave and that deep S wave. And then here you can see that small Q wave and that really tall R wave. And that's basically, I mean, you all know how to diagnose a lateral wall infarct or scar on an EKG. I'm not going to go into that. So moving on into low voltage criteria. So this is basically anything that gets in the way of the electrical conduction of the heart. Anything that will get in the way of the heart, including anything that could cause any kind of infiltrating disease into the heart, and anything that will cause interference between the heart as to the skin of the chest wall. So the criteria for low voltage criteria is anything less than 5 millimeters in the limb leads. So if you don't see tall R waves or you don't see deep S waves, that leads to criteria as long as it's within that 5 millimeters within the limb leads. And then if you're looking at the precordial leads, anything that's less than 10 millimeters. And the main differential that we create for that is anything that air, fat, or fluid. So things that are included in air is like a pneumothorax or an emphysema. In terms of fat, we can think of a big obese person, and that that's not likely going to change. So if there's a new onset of a low voltage criteria, you'd be hard pressed to say that the low voltage is because of the person being obese. And then there's obviously fluid, and all of you will know that things like pericardial effusions or pleural effusions can get in the way of the electricity passing quickly and at full conductance to the electrodes. So it kind of makes intuitive sense why that would cause low voltages. Another thing I would add, but I never really got any confirmation on this, is amyloid or any infiltrative process into the heart, like sarcoid or hemochromatosis, can kind of dilute the electricity that the heart conducts to the chest wall. So that can cause a low voltage also. So this is an example of an EKG that does have a little bit of a low voltage. It doesn't quite meet criteria, but it's getting there. Like I said in the previous slide, you can see that there are QRS complexes that are less than 5 millimeters in the limb leads. It's 1, 2, and 3. And then if you look at the precordial leads, a lot of the QRS complexes are less than 10 millimeters altogether. And you can see that there's this electrical alternans pattern that would be more indicative of something like cardiac tamponade. And this is the EKG of a woman with metastatic breast cancer with weakness and shortness of breath. As you can see, this meets those same criteria we were talking about for low voltage. And then you can also see that there's even more electrical alternans here, and you can see that especially in V3. If you look down at that lead, one QRS complex is pointing up, another one's pointing down, and that is consistent with a pretty large pericardial effusion, likely secondary to her breast cancer as the neoplastic process there. Okay, so moving on to bradycardia, I'm going to discuss a small, quick little differential for bradycardia that occurs with a regular rhythm. So we're not talking about irregular rhythms or anything like that, just anything that is regular with a heart rate less than 60 beats per minute. So the differential for this is pretty short. It's just three quick things that I think about is sinus bradycardia, any kind of AV block, and then a sick sinus syndrome. So sinus bradycardia is pretty simple, is anytime you see that the rhythm is specifically sinus, so as the P wave is coming from the sinus node and it's regular and everything's fine, there's no blocks or anything like that. And then the other thing that you have to worry about is any kind of AV block. So this is actually a patient that has Morgani-Adams-Stokes attacks preceding the development of kind of a persistent complete heart block, and this is kind of what it would look like. So in this EKG, I didn't map it out, but you can see if you look down at the rhythm strip down in leads 2, you can see that there are P waves that kind of precede most of those beats, and then if you look after that third beat, right after that T wave, there's another little P wave that pops up, and you can see that these P waves tend to kind of be marching all the way through without any real association with the QRSs. So this is an example of a third degree heart block, a complete heart block, in which there's no temporal relationship between the P waves and the QRSs. So here you can see the QRS complexes is pretty obvious, but then if you look closely you can see some P waves here and they don't correlate at all with the QRS complex. They're just kind of interspersed and they don't really correlate. One thing that is not necessarily shown here all that well, but you can also look at the ratio of P waves to QRS complexes, and if that ratio is in favor of the P wave, in other words, there's more P waves in the EKG than there are QRS complexes, you can say with a pretty reasonable degree of certainty that there's going to be a third degree or a complete heart block. So moving into a sick sinus syndrome, this is a group of basically a variety of cardiac arrhythmias that occur in the elderly, can occur kind of with sinus pauses, arrests, inappropriate bradycardia, tachycardia. Basically the sinus node does kind of whatever it wants, and it can flip-flop between sinus bradycardia and sinus tachycardia. It's not terribly obvious, and I couldn't find any good examples out there, but it's just something that you should know about. So moving into tachycardia, again, we're going to be looking more into regular rhythms and something that has narrow QRS complexes, and anything, the definition of tachycardia being any heart rate greater than 90 beats per minute. So looking at this kind of diagram, there's different kinds of tachycardia. There's wide QRS complexes, there's narrow QRS complexes, and that's helpful to figure out which part of the zoo you're in, and it's helpful in terms of narrowing your differential diagnosis. So we're going to be talking about this specific box here. Any skinny QRS complexes that's regular and also has tachycardia. So the differential for narrow QRS complex tachycardia includes sinus tachycardia, any kind of re-entry atrial tachycardia, which will include AV NRT and AV RT, as well as atrial flutter with a 2-to-1 block. So AV-RT and AV-NRT can be pretty difficult to diagnose just looking at an EKG. AV-RT specifically is a supraventricular tachycardia, so a tachycardia that comes from above the ventricles or above the AV node. Basically, there's AV conduction, and then there's an accessory pathway that causes a reentrant circuit that the electrical signal basically ends up going around and around and around to create a regular tachycardia. Wolff-Parkinson's-White is an example of this. This, as you know, and has been tested multiple times on board exams and step exams. It has a shortened PR interval as well as that delta wave. And then in contrast to that, AV-NRT is specifically a nodal reentrant circuit. So there's no real accessory pathway in this in this specific arrhythmia. It's just that there's a premature beat that comes in at the right time, and then there's a re-entrant circuit that goes around and around and around in the node specifically. So looking at this patient, a 65-year-old gentleman with chest pain and hypotension, the main thing you need to look for is any kind of P wave that you can identify. And in a man with chest pain and hypotension, the differential is pretty short. And if you look here, you can kind of see some P waves. There's a sinus rate that's going at 140 with a rightward axis. There's a little bit of an incomplete bundle branch block pattern there. And then you can also see a pretty deep S wave in leads 1, and then a Q wave in 3, and then an inversion of T waves in 3 in AVF as well as V3. So this would be a pulmonary embolism, and sinus tachycardia is the rhythm here. So here you can see those S waves right here, and then that Q wave right there in lead 3, and then the inverted T wave. So next, this is a 72-year-old gentleman with dyspnea and weakness, and if you look here, this guy has got a pretty quick rhythm, and it's regular. You can kind of see a little bit of a sawtooth pattern here, which would be consistent with atrial flutter with 2-to-1 block, and that's a diagnosis here. So moving on to a younger patient, this is a 28-year-old female with sudden onset of palpitations, and while she was having these palpitations, she's got this kind of EKG, and you can see here that there's no real obvious P waves that occur right before the QRS complexes, and it is a narrow complex tachycardia at a rate of 150. So because the rate is 150, you immediately think about atrial flutter, but since there's no obvious sawtooth pattern here, you can pretty reasonably conclude that that's not the case. Here you can see significantly there's a ST segment distortion that's best seen in leads V3 as well as 2-3 AVF. Here you can see that there's a small little ditzel right before that positive deflection that makes a T wave after the QRS complexes, and that small little ditzel is likely the P wave, and it's going retrograde. So because it's going retrograde, it's going to be a negative deflection after your QRS complex. So because we've seen this, the differential is either AV-NRT or the AV-RT that we discussed previously. Moving on to another patient. This is a patient that actually presented to the Jewish hospital, and like our previous patient, this is a lady that had lightheadedness and a racing heart, and while she was symptomatic, she got this EKG, and you can see here that those small little ditzels after the QRS complexes are pretty consistent throughout the EKG, and then after she has those retrograde P waves, she has a positive deflection that makes up the T wave. And then when she was not having these episodes, this is what her EKG looked like, and you can see that she's got good P waves here that occur throughout the EKG. They're upright and they're coming from the sinus node. So she got an EP consult, and they may need to do some kind of EP procedure for her. So moving on into V1, when I was on my away rotation, one of the attendings really harped on the usefulness of this specific lead, just because it's so informative, and there's 4 big things that you can be able to build a differential for just by looking at V1. So you can look at the R wave there, the ST elevation, an RSR prime pattern, and a wide QRS complexes, and you can build a pretty robust differential for what's going on in the EKG and diagnose your patient best. So like I've mentioned before, a big R wave in lead 1 is anything greater than 7 millimeters. The differential for this is a posterior infarction, right ventricular hypertrophy, or WPW. You all know what these look like, or we talked about them before. I'm not going to go into too much depth with them here. Moving on to ST elevation and leads V1, sorry. Myocardial infarction is not the only thing that can cause ST elevation in this specific lead. This differential is pretty broad. It's got left bundle branch blocks, which you all know about, MIs, LVH, repolarization, PEs, pericarditis is going to cause an ST elevation in all of the leads, as you all know, as well as Brugadas can cause some ST elevation, and then hyperkalemia. And then going specifically into hyperkalemia, it's important to know that this causes peak T waves, as you all know, but peak T waves is going to occur in all the precordial leads, not just one specific lead. And then also it's important to not confuse the T waves of hyperkalemia with other abnormalities that can cause T wave changes, like CNS insults. You can see T wave inversions there, and if you see pretty diffuse T wave inversions, you should think more CNS stuff, like a subarachnoid hemorrhage, as opposed to heart issues. You can also get T wave inversions from catecholamine surges. You can get it from Takotsubo's or Yamaguchi's, potentially from pulmonary edema, although I think that's pretty rare. And then that's really about it, I think. Also, with these changes, this is something that we see typically with our ESRD patients, but there's other electrolyte abnormalities that can be caused from missing dialysis. Something that we don't see as often is something like hypocalcemia, which could present as QT prolongation because the calcium-dependent conduction through the myocytes tends to be slowed due to the lack of calcium. So this is a 30-year-old lady with lupus. She now has severe chest pain. One of the issues that stands out immediately here is you see that PR segment depression, which kind of makes you think that there's some ST segment elevation. I think the ST segment is slightly elevated and leads 2-3 AVF, and you can kind of see it a little bit in V3 and V4. All of this is kind of consistent with pericarditis, but one of the things that I think is a little bit more specific for pericarditis here is that PR segment depression. And then consistent, or in accordance with what we were talking about earlier, that V1 lead also has that ST segment elevation. So this is a 25-year-old man with syncope, and you can see pretty clearly that if you look at leads V1, he's got an ST elevation, but what this really is like an RSR prime pattern. So there's a small R wave, there's an S wave, and there's another R wave that kind of looks like a right bundle branch block. So this is actually like Brugada syndrome, especially given this guy's history of syncope, and is a pretty young gentleman, probably pretty healthy. One of the main issues that causes this constellation of symptoms, as well as this EKG, is going to be Brugada syndrome, which is a sodium channelopathy. And what ends up happening is that they have ST wave changes that you can see kind of throughout the precordial leads, and ends up causing syncope. This is a familial issue, so the family history will probably have syncope also, and changes like this. And one important thing to note is that these changes are not permanent, so his EKG does not always look like this. It just happens whenever that issue with that sodium channel is more pronounced, and you can actually give certain medicines to elucidate this kind of EKG if you really need to diagnose it. So this is a 35-year-old lady with a severe headache and then coma, and the obvious thing that stands out here is a pretty obvious T-wave inversions that occur diffusely throughout the EKG, and given the history of a severe headache and then a coma, it's consistent with subarachnoid hemorrhage. And the other thing I said to watch out for is hypocalcemia, which is going to have a reduced PR interval. That, like I said, that prolongation of the QT interval, sometimes you get a prominent U wave, prolonged ST and T wave depression. Just something to watch out for when you're thinking about electrolyte abnormalities in ESRD patients. So moving on into that RSR prime pattern in V1, we mentioned one thing that's in the differential is the Brugada syndrome, but the other pathologies that can lead to that pattern is that right bundle branch block as well as ASDs. So mix-up, I think, usually has a couple questions on ostium primum and ostium secundum as a cause for RSR primes in V1. And the way you differentiate ostium primum and secundum is through the different axis deviations that they cause. So moving quickly into wide complexes in V1. The differential for wide complexes in V1 is that right bundle branch block, which you know about, left bundle branches, WPW with that slurred delta wave can prolong your QRS complexes, any kind of, as well as any kind of idioventricular conduction defect. And the definition of a wide QRS complex, is anything greater than 120 milliseconds or 3 little boxes. So this is what a left bundle branch looks like. On the left here you see a deep S wave in V1 and a little bit of a T wave there. And then you see in V6 mostly an R wave that has a little notch in it, and that most of this is just pattern recognition. You just got to see a lot of them to really be able to pin them down. And then the one thing that you can easily recognize is that right bundle branch pattern with a wide complex QRS pattern that's taken up more than 3 little boxes, as well as that RSR prime pattern. So a small little upward deflection creating that initial R wave, a downward deflection creating the S wave, and then that second larger R wave, which we then call a R prime. So this is an example of a left bundle branch block. As you can see, there's that deep S wave, and then that's in V1, and then in V6 you see a little R wave there. And then if you look at how wide the QRS complexes are, you can see that they are greater than 3 little boxes. And this is another example. In V1 you can see that there's an RSR prime that would be consistent with the right bundle branch block here. And then this is another example of a left bundle branch block. So this is a 28-year-old woman that has this EKG done after she had a cardioversion, and if you look closely here you can see that there is some slurring in her QRS complex, and that the QRS complexes are about 3 little boxes here, but given her history of needing a cardioversion and that slurred upstroke, this is all consistent with the Wolff-Parkinson-White pattern, and this is usually on our in-service exam or board, so it's something to recognize pretty easily. So that's all I had. Really, I know it was probably pretty quick and in-depth. If you have any questions, feel free to ask me, but I think this is a pretty good approach to looking at EKGs, is knowing a handful of specific findings and then knowing a short differential to help lead you and guide you when you're looking at these EKGs. If you have any questions, absolutely let me know. I'm here if you need anything else. All right, thank you.